I would first off start introducing our first speaker, Dr. Eric Liu. Dr. Liu is a neuroendocrine tumor specialist of not only national but international repute. He is currently practicing and co-directing neuroendocrine tumor program in Denver, Colorado, but he started his career at Vanderbilt University, where he developed their neuroendocrine tumor program. Dr. Liu also had opportunity to do a neuroendocrine tumor specific fellowship under the tutelage of one of the giants of neuroendocrine cancers, Dr. Kjell Oberg in Uppsala University, Sweden. Dr. Liu is not only a gifted surgeon, but he is a super neuroendocrine tumor patient advocate and a neuroendocrine cancer researcher par excellence. In fact, I just found myself citing one of his research paper published in Oncologist, looking at a very important blood-based biomarker in neuroendocrine tumor. Nobody in neuroendocrine tumor community needs any introduction when it comes to Dr. Liu. He is a superstar, and I'm so happy that I got an opportunity to introduce him today. I'm eagerly looking forward to listening to his talk. With that, I would like to introduce Dr. Liu. Please give him a round of applause.
Good morning, everyone. It is great to see you all, and I actually gave half of my lecture already, so let's see if this is okay. Welcome to our I guess, first virtual patient meeting. And as always, I always want to thank the Wayman family for all the energy and work that they put into putting these meetings together. They've been doing this for many, many years, and it's gotten more refined over time. And despite the fact I miss seeing you all, which is actually most of the fun, disseminating information and knowledge is still very, very critical. And in fact, maybe we can actually reach more people now. So my job in the next now 15 minutes, I guess, is to go over the general clinical overview of neuroendocrine tumors. I will do this as quickly as I possibly can. However, there's just more to it than I can possibly do. So we'll just try our best. And then the other thing too is Dr. Mayer is going to talk about all the nuclear aspects of it. So the nuclear imaging, the nuclear therapies, and those kinds of things. So that I will kind of gloss. I won't really go into. He'll do a much better job than I will. And then of course, we'll be around. So if you have any questions, feel free to ask us later. Okay. So my goal today is to, at least for the next 20 minutes, is to give you a kind of a basic introduction to what neuroendocrine is, how we diagnose it, the pathology, and the therapies. I cannot do this in 20 minutes, but I hear the next speaker is very, very sweet and kind, so hopefully he'll cede a little bit of time to me. But we'll try our best, okay? Okay, so what are the basics of neuroendocrine? So neuroendocrine is a very, very complicated disease. And by the way, for anyone who's ever seen my lectures before, if I tell a joke and you've heard it before, you still have to laugh, okay? So let me just make that clear. But neuroendocrine it's a complicated disease because it's a whole class of diseases. And so people will ask me all the time, how can you possibly make a career out of doing neuroendocrine? Because that's essentially all I do. And then my wife says all the time, well, how do you plan on making a living out of doing neuroendocrine? And I'm like, don't worry, honey, it'll be okay. So neuroendocrine, the reason it's called neuroendocrine is because because they're smart, and endocrine because they function through hormones, okay? And these are tiny little cells that control many, many aspects of your life that you don't even think about because you don't want to think about it. Imagine if you had to think about how to move your breakfast from your mouth to your bottom all day long. You would do a terrible job and you'd probably have diarrhea and vomit all day long. But there are these teeny tiny little control cells scattered throughout your lungs and throughout your digestive tract, which do this all for you. And they do that through hormones. And you can see here, these are the most famous hormones we see: serotonin, insulin, gastrin, glucagon, BIP, somatostatin, histamine. Well, those are probably 7 hormones out of 700, if not 7,000 hormones that are created from your body. So it's very, very complicated. And the interesting thing is that all of these cells, almost all of these cells, express a receptor called somatostatin receptor, so a little lock and key system. And Dr. Mayer will talk about how we've exploited that. But this is kind of how it works. And it's very complicated because it comes from so many different things. So just a little bit of definition, because you've heard probably multiple different words to describe these things. But neuroendocrine tumors are these tiny tumors that usually grow pretty slowly, that are derived from this endocrine system, this diffuse endocrine system, and they can secrete hormones. If you've heard the word carcinoid before, carcinoid's an older term. We're trying to kind of get rid of it, but carcinoid is a term for a neuroendocrine tumor that comes from a tube. So it comes from a breathing tube. If it comes from a digestive tube, those are usually called carcinoids. Okay, but that's still under the umbrella of neuroendocrine. So neuroendocrine is the kind of more general term to cover everything, and the more modern term. So we use neuroendocrine tumor, neuroendocrine cancer, however you want to call it. That's what we use. Right? It's complicated because you can see it comes from many different places. So a lot of them will come from the pancreas, and they can secrete different hormones and behave differently. Some of them can come from the lungs, some can come from the small intestine, some can come from the rectum. So you can see on this slide alone, there are probably 10 or 15 different types. And each of those has 3 different branch points, and each of those has different branch points. So neuroendocrine probably is like 70 to 100 different diseases. And so when you see someone, they may not know all the difference. There are not that many people who can sniff out the differences between all the different kinds of neuroendocrine tumors. So just be aware, if you can, go see a neuroendocrine specialist, okay? And I'll show you, it's a complicated disease because people have problems. They can have hormonal excess. They can have mechanical complications. You shouldn't probably have a little softball somewhere where it doesn't belong in your belly. They can have terrible nutritional problems. They can have cardiac problems. They can have problems even with procedures like anesthesia. So it's a complicated disease and a complicated process. So you as the patient or the caregiver want to surround yourself with people who know what they're doing, okay? And this is obviously not a disease without a face, right? So this is Dave Thomas, the founder of Wendy's. He also had a neuroendocrine of the small bowel. This is Audrey Hepburn. She had kind of a variation of neuroendocrine. Her stomach hurt all the time. And previously, the most famous person to ever have neuroendocrine was Steve Jobs. And he had pancreatic neuroendocrine tumor, and he died, younger than he should have, unfortunately. And of course, now the most famous person to die of neuroendocrine is Aretha Franklin. And look at the headline. What is that? So you're not alone when you think that no one understands your disease, because most people don't. And that includes a lot of healthcare professionals. So those are all efforts we're trying to work on. So epidemiology, that's just the numbers, okay? There are a lot of patients with neuroendocrine. You'd be surprised. Over the past 40 years, it's jumped almost 7-fold, the number of new patients who get it in the United States. And you can see here, there are a lot of people with it. So back, maybe in 2004-ish, there were about 100,000 people they thought who had it. Well, in 2014, that's jumped up by over 50% to now 170,000. And that's just a gross estimate, probably an underestimate. So there are a lot of people who have neuroendocrine and walking around and living with it. Because people who have stomach cancer and pancreas cancer and esophagus cancer and liver cancer, they just don't survive. Whereas neuroendocrine people can survive, which is great. That's the goal, right? Of course, that's the goal. But now how do we figure out what is neuroendocrine? How do you make the diagnosis? This is extremely, extremely difficult, okay? And that's why it sometimes takes 7 to 9 years to figure out what's going on before someone makes a correct diagnosis. And I'm sure a lot of you have experienced this. So look at the symptoms. A little diarrhea, a little bit of rash, a little bit of flushing, a little bit of stomach pain, a little bit of gallstones, blood clots, abdominal pain, swelling, obstructions. Those are very common things, right? I mean, extremely common. And look, diarrhea and flushing. I mean, some of you have probably had that today, right? For various reasons. So those are the things. Anger, my goodness. I mean, how many times has Marianne been angry at me? Clearly. So those are kind of very, very soft symptoms that your PCP would never, never consider to be secondary to a rare cancer like neuroendocrine cancer, right? So it's not easy to figure out, except when you get and the interesting thing is about 70% of the patients actually have no syndrome. They just present with a random mass that they find from a scan for no reason, from a incidental colonoscopy. So it's tough to figure out. But when you do the imaging, like the CAT scan or an MRI or an ultrasound or the old scan, the Octria scan, which hopefully no one's getting anymore. I hope you're not getting that anymore. And our slightly newer scan, the gallium dotatate scan, these are techniques that you can use to find it. And it usually isn't that hard. If you look here, I'm sorry, I don't have a pointer, but if you look here, there's that kind of gray mass and a little bit on the right side of that screen there. That's a pancreatic neuroendocrine tumor. And here's another one here. I know it's a little hard to see, but right in the middle of that white web of blood vessels, there's a little mass there. And radiologists should be able to see it. So the question is if you get a scan or not to kind of figure out what's happening. Here's an example of, right there, see, there's a target. Here is an MRI. And forgive me, I don't have the pointer, but if you look on the left side, that's an MRI. And if you look on the right side, there's a CAT scan. And if you look at that white tube, kind of just off to the left a little bit in the middle, you can see on the CAT scan, the kind of the gray one, there's nothing there. But if you look next on the same kind of area on the MRI, you can see the tumor. So you can see how different technologies can do different things for you. And then if you go to nuclear, and I won't talk too much about it, but you can see these scans have been extremely important. This is the old Octria scan, which hopefully we will just do away with in the next few months. There is the good old-fashioned PET scan, which we do for aggressive cancers. And then here are some of the fancier ones. And Dr. Mara will talk to you all about that. I do want to show you just this one gallium scan that we did. So this is actually a famous scan, I think anyway, of a lady who had an Octria scan, which looks totally stone cold negative, right? She got a gallium scan and it showed multiple lesions inside of her liver, right? And this happens to be the very first gallium scan that we did in 2010. So a decade ago. I can't believe I'm getting that old. But this is the very first scan that we did. And hopefully it's helped a lot of people since then. And so this is our efforts at the FDA to get it approved. It was really great. Good team effort. Okay, so that's a little bit about diagnostics. Let's talk about pathology a little bit. So pathology is when they cut it out or they do a biopsy of it and they look under the microscope. And essentially neuroendocrine tumors come in three flavors. They come in the good, the bad, and the ugly. And you can see they're low, intermediate, and high. And basically it's kind of how aggressive it is. People who have low-grade neuroendocrine tumors, usually the tumors grow very, very slowly. It can be aggressive. It can spread very, very easily, but they tend to grow very slowly. Whereas the high-grade ones tend to grow fast and are more aggressive and can be quite difficult to control. And you can see here they look very different, even under the microscope. They're nice and pink on the left side and purple and ugly on the right side. And the pathologist has to look very carefully and give you a lot of information about these things. So these are the types of information that your clinician needs to really figure things out, okay? And so that's the pathology. So that's a very important thing. It's hard for you to interpret, but it's important for the specialist or your doctor to interpret. But let's get into therapies a little bit. So there are actually a bunch of things you can do. So for a relatively rare zebra kind of disease, we actually have a lot of tools in the toolbox. And surgery, which I'll talk about in a second, is actually a very powerful one. And I'm a surgeon, so just, all disclosures there. But I believe very much in it because I've helped so many people with it. And the problem is when someone says, oh, you can't have surgery, it's probably a medical doctor or someone who doesn't know how to do surgery, or maybe a local general surgeon who is not familiar with the disease. They may not know exactly how to do it or how it can help you. So those are things to consider. But we do have suppressive hormones. We have hormone synthesis blockade. We have these targeted therapies. We have good old-fashioned chemotherapies, which can work in certain circumstances. We have something called liver embolization. And of course, the new kid on the block is the PRRT, the peptide receptor radionuclide therapy, which Dr. Mara will talk about. And these are all tools in the toolbox which have to be used over and over and over again to get you feeling well. And really, you have to think of neuroendocrine as a very different kind of a beast. Okay, this is not lung cancer. This is not aggressive colon cancer, which is very sad because, as you probably all know, Chadwick Boseman, the actor, just died today of colon cancer. So it's a different disease. So you have to have tumor control, you have to have symptom control, and you have to have hormone control. And only when you have all of these three things can you have comprehensive disease control. And there are very few people who can really kind of do all these things for neuroendocrine. So just kind of keep that in mind, okay? So what I like to preach a little bit is the first therapy you should think about, is you should think about cutting this thing out, okay? Because it helps a lot. And then when something else happens, you want to think about your second therapy, you should think about cutting it out again, okay? And then when something happens and you need to think about it, you probably want to think about cutting it out again, okay? Because neuroendocrine tumors respond very well to surgery. It's not perfect, and I'm teasing a little bit. I'm trying to kind of make a point, right? Not everyone should have surgery right away. So there's always thinking about it. But thinking about surgery is very important. And I will show you the slide again later, okay, to make the point. As far as medicines go, the medicines are very, very important and powerful. We're very fortunate to have them. We have the somatostatin analogs, okay, those are the lanreotide and the octreotide, and interferon, which is kind of an older medication, but they work very well for tumor control and for controlling symptoms. So you get 2 for 1. So many of you are familiar with sandostatin, probably for decades. It's been around for 30 years now. And the slightly new kid on the block is somatuline or lanreotide, both amazing, amazing medicines who have probably helped millions of people across the world. And you can see here, not only are they good for symptom control, but they can help with tumors as well. So you can see these are some of the other medicines too, but you can see if you give the medicine, you can slow down the growth of the tumors. And then we have other medicines such as sunitinib, also known as Sutent, or everolimus, also known as Afinitor, which are pills, which also slow down the growth of the tumors, right? So we have some good medicines. We also have some chemos. This is a combination of what's called capecitabine, which is a chemotherapeutic pill, and temozolomide, which is another chemo pill. And you can see there that a lot of patients can actually get some shrinkage from this kind of chemo. So that's actually really terrific. It's a good option to have. We also have medications that can block the production of hormones for people who are really sick from the hormone production. We have something called Telotristat or Zermello. And they tested and they found that people who took the Zermello were actually could decrease the amount of diarrhea that they have, and it decreases the amount of serotonin that's being made. So it's very effective, very useful. And of course, there's some good old-fashioned chemos that still have an effect, especially in those high-grade, very aggressive kind of neuroendocrine cancers. Again, you have to decide and think very carefully about which ones work. And then for people who have a lot of disease in their liver, you can actually just treat the liver itself with what we call embolization. We can squirt in like oils and beads, and we can even squirt in radiation. Again, very careful thought should be placed when you're deciding on the therapy, because it can be very tricky. Some of the therapies can be toxic, and some of the therapies can work in the short term and then kill you in the long term. So we have to be very, very cautious about these things. So, I mean, I blazed through all those therapies and kind of what you're going through, but here is really the crux of it. So the art of neuroendocrine is not what to do. It's when to do it, okay? I will pause so you can look at the slide and laugh, okay? Thank you, because I am that ancient Chinese neuroendocrine specialist. But that's really what it is. Neuroendocrine is a marathon. It is not a sprint. Well, in some aggressive cases, it's a sprint, but in general, it's a marathon. And so you don't want to fire off all your bullets at up front. You don't want to burn any bridges. I mean, whatever analogy you want to use, or it will apply. So you have to think very hard. So when a patient comes to see me, for example, I'll study their case and I'll think, well, what am I going to do for this person in 6 months, in a year, in 5 years, in 10 years? And so those are the things, that's the goal. That's the goal. And hopefully we can work together and figure that out. So just be aware that it's true. For neuroendocrine, every individual is different, right? I will see 15 to 20 neuroendocrine patients a day, and each one is different. Each one that walks into the room is different from the one that walks out. So the zebra, and hopefully Marianne explained the zebra thing already. It is a very, very apt analogy, because none of their stripes are the same. And so we just try to lead them to water so that we can be successful and help you, right? Because my goal is always to help you live a better life as well as living a longer life. And in addition to NCAN, which is a wonderful organization that I cherish, you guys know, I also work I work very closely with what's called the Healing Net Foundation, which is a foundation a little bit different from NCAN. We actually work very closely with NCAN and the Wayman family, but the Healing Net Foundation was created to help kind of bridge a lot of gaps. A lot of doctors don't know anything about neuroendocrine. I'm sure all of you know that. And so we're doing our best to create more awareness and education for those community. I'm a community doctor, right? And so trying to help those doctors do that. And so thank you very much. I hope that was helpful.